We begin the knee examination by assessing the quadriceps tendon and the suprapatellar recess. To visualize the quadriceps tendon properly, ask the patient to slightly flex the knee or contract the quadriceps muscle. Here we can see the quadriceps tendon, the suprapatellar recess, and the suprapatellar and prefemoral fat pads lying deep to the tendon. When we place the probe transversely, we obtain a cross-section of the quadriceps tendon. Moving the probe proximally gives a transverse view of the quadriceps muscle, the rectus femoris and vastus intermedius. Sliding the probe laterally reveals the vastus lateralis and medially the vastus medialis. Placing the probe lateral to the patella allows us to evaluate the lateral patellar retinaculum. We can also roughly assess patellar tracking to check for lateralization. Measuring lateralization in millimeters should be considered only approximate. On the medial side, we evaluate the medial patellar retinaculum. The central thickest portion of this structure represents the medial patellofemoral ligament. Next, we examine the patellar tendon. It's best done with the knee flexed to about 90 degrees. In this view, we can see the patella, the patellar tendon, and its tibial attachment. The patellar tendon can also be viewed in transverse section. Deeper structures include Hoffa's fat pad, and beneath it, the anterior cruciate ligament. Here we can see the outline of its tibial attachment. Since the entire ligament cannot be visualized, it's useful to assess its tension during the anterior drawer maneuver under ultrasound guidance. Here we can see normal tension of the anterior cruciate ligament. Next, we move to the medial side of the knee to examine the medial collateral ligament. Here we can see its femoral attachment, its course along the medial aspect, and the distal portion of the ligament. We follow it all the way down to its tibial attachment. Note that this attachment lies about 6 to 7 centimeters distal to the joint line in the region of the pes anserinus, just posterior to it. On the medial side, we also evaluate the medial meniscus, which lies deep to the medial collateral ligament. We assess it both anterior and posterior to the ligament by moving the probe accordingly. We'll examine the most posterior part of the meniscus later when the patient is lying prone. On the medial side, we also evaluate the region of the pes anserinus. We usually don't need to distinguish the individual tendons, although it's possible to do so. The most common pathology here is overuse, seen as thickening and reduced echogenicity. Moving to the lateral side, we examine the lateral collateral ligament and visualize its femoral attachment. We follow the ligament toward its attachment at the fibular head. Note that the lateral collateral ligament merges with the insertion of the biceps femoris tendon. The biceps femoris splits into two distinct limbs, one lying slightly superficial, the other deep to the lateral collateral ligament, both clearly visible as we follow them in longitudinal view. Rotating the probe allows us to visualize the biceps femoris tendon in longitudinal view. It's best seen with the patient prone, examined from posterior. On the lateral side, we evaluate the lateral meniscus. Here, a small vessel can be seen in its external portion. It's pulsatile and should not be mistaken for a small cyst. By moving the probe anteriorly and posteriorly, we can evaluate the meniscus. Note that at the junction of the middle and posterior thirds of the lateral meniscus, the popliteus tendon passes through its capsular portion. This area is known as the popliteal hiatus. The popliteus tendon attaches to the femur near the attachment of the lateral collateral ligament. By slightly rotating the probe, we can visualize the popliteus tendon in longitudinal view. We can also visualize the distal attachment of the iliotibial band to Gerdy's tubercle on the anterolateral aspect of the tibia. Here we see its distal attachment and course as it passes over the most prominent part of the lateral femoral condyle, a common site of irritation. Roughly midway between the patellar tendon and the iliotibial band, we locate the attachment of the anterolateral ligament. Here, the anterolateral ligament attaches to the tibia, an area sometimes injured and often associated with anterior cruciate ligament tears. If an avulsed bony fragment is present, this represents a second fracture. Next, ask the patient to flex the knee deeply. In the transverse view, we assess the articular cartilage of the trochlear groove and the medial and lateral femoral condyles at the patellofemoral joint. Here the cartilage shows an area of mildly increased echogenicity. On the exported recording, the image appears slightly less distinct because the compression is not lossless. In the central region, there is also mild thinning of the cartilage. These findings represent a borderline appearance between normal and pathological, consistent with early chondromalacia. We assess the femoral condylar cartilage in both transverse and longitudinal planes, evaluating its thickness, surface contour, and echogenicity. Healthy cartilage is nearly anechoic and about 2 mm thick. Remember that if the cartilage is slightly thinner, for example around 1.6 mm, but the thickness is uniform throughout the joint, the cartilage remains anechoic and its surface is smooth and regular, it should still be considered normal. Similarly, on the lateral side, we evaluate the cartilage of the lateral condyle. It can also be viewed in transverse and longitudinal planes and measured if needed. Next, ask the patient to lie prone and examine the posterior aspect of the knee. Here we can see the posterior horn, that is, the posterior third of the meniscus. The meniscus is best assessed dynamically, as small tear lines may become visible only during flexion. Here we see a meniscus with normal echogenicity and contour, both at rest and during flexion and extension. The same technique is used for the lateral meniscus. When examining the junction of the middle and posterior thirds, note the popliteus tendon traversing the meniscus. As on the medial side, we evaluate it dynamically during flexion and extension. During movement, the meniscus moves normally. In the central part of the popliteal fossa, we can visualize the posterior cruciate ligament in longitudinal view. It appears slightly less echogenic than the surrounding tissue. For better visualization, trapezoidal imaging or a convex probe may be used. We can check the ligament tension during the posterior drawer test. In transverse view, we evaluate the proximal attachment of the anterior cruciate ligament. When injured, this region shows a hypoechoic area. Here we can see the normal appearance of the attachment and surrounding tissues. By positioning the probe longitudinally, we attempt to visualize the anterior cruciate ligament in longitudinal view. In this region, it's not as clearly visible as the posterior cruciate ligament, but this is where it is located. In the popliteal fossa, we also identify other key structures: the tibial nerve, the popliteal vein, and the popliteal artery. We can trace the tibial nerve proximally to the sciatic nerve. The branching of the common peroneal nerve can be seen here, just at this point. We check the compressibility of the popliteal vein using a compression test. On the medial side, we should always assess the gastrocnemiosemi-membranosus bursa. Here, a small amount of fluid is present, but this would not qualify as a Baker cyst given its small size. In transverse view, the bursa lies between the medial head of the gastrocnemius and the semimembranosus tendon. The semimembranosus tendon can also be assessed in longitudinal view. At this attachment, tendinopathic changes appear as thickening and reduced echogenicity, occasionally progressing to partial or complete tears. This concludes the examination.